Right. We'll go ahead and kick things off here. So welcome, everyone. Thank you for joining today's webinar, Revealing Undetected Heart Attack Risk, Clinical Use Cases for Multi-Ancestry Polygenic Risk Score Testing. My name is Colleen Lyons. I am the Business Development Manager at Alelica, and I will be moderating today's webinar. So today, our speaker, Dr. Rigved Tadwalkar, will be providing insights on how PRS is being used by his practice and by other leading healthcare providers to identify patients who are at a high risk of heart attack, but who are invisible to the standard of care. So it's my pleasure to introduce to you today's speaker, Dr. Rigved Tadwalkar. Dr. Tadwalkar is a consultative cardiologist and partner at the Pacific Heart Institute. He is board certified in multiple specialties, including cardiovascular disease and cardiovascular CT, and holds fellowships with the American College of Cardiology and the American College of Physicians. Dr. Tadwalkar plays a key role in clinical leadership, research, and education, and is widely recognized for his expertise in cardiovascular disease prevention and patient-centered care. Dr. Tadwalkar is also an influential medical voice in the media, serving on the Forbes Health Advisory Board and frequently being featured in outlets such as US News, LA Times, and WebMD. So we're very honored to have him with us here today. So Dr. Tadwalkar is going to provide the presentation, and then we will have a Q&A session at the end. So you can feel free to pop your questions in the Q&A box throughout, and we'll address as many as time permits at the end of the presentation. So with that, I will turn things over to Dr. Tadwalkar to begin.
Thank you so much, Colleen. So I'm just going to go ahead and share my screen. Appreciate the introduction. Let's make sure we're nicely set up here. Let's see here. Okay, good. Okay. Does that look okay, Colleen? Does it look like we're displaying correctly? Okay.
It looks good.
Wonderful. Yep. Okay. Excellent. So everyone can hear me loud and clear. This is great. Okay, so first and foremost, thank you so much for taking the time. I know in the current era, sometimes we get inundated with these meetings. So really appreciate you, being here. This is one of these topics that I think is long overdue. It's something we don't discuss often clinically, and it's ready for prime time, which makes it all that much more exciting. So I'm happy to speak with you about today. The presentation today is going to be quite impactful, pretty efficient. So we'll get right into it. And we're going to talk about revealing undetected heart attack risk, and the clinical use cases. We'll have real cases at the end for multi-ancestry polygenic risk score testing. Now, for those of you who are not familiar with polygenic risk scoring, PRSs, polygenic risk scoring, are a weighted sum of millions of common variants across the genome that are known to increase susceptibility to certain diseases and traits. And while today we're talking about coronary artery disease, you can in fact do PRSs and run them for a variety of different conditions. So this is burgeoning across the entire spectrum of medical disease. Today, however, we will focus on coronary disease. And PRS describes an individual's risk of a disease or trait based on these common genetic variants spread across the entire genome. So this is a little bit different than monogenic testing for genes, which you may be more familiar with. When there are specific genes that we've identified, we go test for those and then go see sort of what you have, whether you have a positive or a negative, and whether that has any sort of specific clinical impact. And hopefully by the end of today's presentation, you'll get a better idea of how polygenic risk scoring is different and actually more clinically actionable for common disease processes. So then that really begs the question, why should we offer PRS testing? Well, in today's era, when there's so much of a focus on longevity, and sometimes I actually had a patient tell me, that people seem like they want to live forever these days. And while that may be true to some degree, I think quality of life is also important as well. But it makes sense that in either of those cases, we want to identify disease risk early. And in many cases, people are coming in with family histories and want to be evaluated early, well before there are clinical manifestations of disease. So it makes sense that if we can do something for them that's actionable and accurate, why not find out early? So this is basically one of the reasons we would want to offer PRS testing. And it facilitates shared decision-making between a provider and a patient. There are many times when you're in an encounter and, a patient may want something specific, but we may not exactly be ready to give it to them, especially if they're in a younger category. This allows for something that can actually meaningfully move the needle forward And you can have a conversation with your patient about offering a tool that could be quite impactful when otherwise you may not leave them with anything specific. And of course, with PRS testing, we can improve precision of existing risk assessments. So our existing risk assessments obviously corner on a few things. Family history. We often look at risk calculators. And while those are helpful, they are, at the end of the day, calculations, right? So there is sometimes a difficult situation. We sometimes are left with a difficult situation where there's a gap between what is calculated and what we're sort of seeing in front of us and predicting risk, right? So it can be a little bit challenging to extrapolate that. And then these monogenic mutation testing, which, oftentimes looks at rare genes, right? So we may not see monogenic abnormalities, but then people can still manifest disease. And this becomes quite problematic. And this is where PRS testing can fill a gap. Now, here's the kicker. This is actually from a Lancet article that looked at individuals and sort of estimating their cardiovascular risk. And it turns out that about 30% of heart attacks occur in patients without any traditional risk factors. So I really want that to sit with you. That means that we could look at family history, we can do our physical examination, you could run an EKG, you could do just about anything. You can sort of try to sort of integrate all of these different clinical assessments, and yet there are 30% of individuals who have heart attacks without these traditional risk factors. So clearly, we are missing a gap here. And in fact, in this article, it very eloquently sort of lays out how polygenic risk scoring can fill this specific gap to identify this patient population. And this is a very important and impactful statement, which is that these patients currently are invisible to the standard of care. So obviously, we want to correct that as best as we can. So polygenic risk score testing identifies these high-risk patients and enables providers to treat them accordingly. So we are looking at improving the standard of care. Now, traditional risk assessments can miss high-risk patients by failing to account for this polygenic risk factor. In fact, you can look at any calculator. You can look at Framingham risk. You can look at your pooled cohorts equation. You can even look at the PREVENT calculator, which is the newest iteration. But in none of these models do we have the polygenic risk factor. And PRS, we have learned through rigorous data, can identify these high-risk patients. And PRS can complement and improve the precision of existing risk assessment tools. So we're not saying that you should throw out your equations or your other sort of markers that suggest that someone's at high risk. This is very much complementary to that. So that begs the question, who should you be testing? And actually, as we go through this, you'll find that the clinical use cases are probably even greater than what's listed on this slide. And in fact, in my own clinical practice, I actually test lots of individuals that don't fit into these paradigms and for a variety of different reasons. And hopefully also that will become apparent as we move forward. But certainly patients with a family history should be tested. Patients with LDLs that are high, we usually say about greater than 130. And patients definitely at borderline or intermediate risk. So these are this is a situation, especially as cardiologists, we often face. Someone seems to be high risk. Maybe we run their stats and we find that they're in this intermediate risk category. And now we're left in a position where we have to sort of use clinical decision making to guide decisions. And this can be a powerful tool to help us nudge us in one direction versus the other. Generally speaking, I would also tell you that younger individuals should be tested. However, when we say young, that can really vary in the clinical setting. And certainly those who are in, we'd say the 18 to 40 year range for sure. But in certain, and I would say like oftentimes we are sort of extending that into say, the 40 to 60 range as well, depending on what the clinical situation is. And hopefully the cases will bring some of that to light as well. So how should you position this PRS test? So you may say, hey, Dr. Tadwalkar, that all sounds wonderful, but is this for me? Like, is this something I could really put into my practice? Like, is this something that I actually will be able to use now? And the answer is yes. It's actually quite straightforward. You could certainly use it as a standalone test because when you're assessing someone and they're establishing care, you want to get a better idea of what their polygenic risk factor is in determining disease. So you can certainly use it as a standalone test as part of your initial screen. For those of you who are in the concierge space, you could use it as part of your executive physical. And even if you're not, and you're getting a better understanding of risk, you could use this. It could be part of a comprehensive health panel, as we sort of alluded to. And it can be a second step to negative monogenic panel results. So case example in this case would be familial hypercholesterolemia, where we're looking at specific monogenic markers. We sort of look at these 4 standard genes typically. And if those are negative, then we're sort of left scratching our heads, like, what do we think about this patient? Are they really, are they really a heterozygote for familial hypercholesterolemia? And are they, have some sort of genetic contribution? And if it's negative, then we'd be in a little bit of a challenging position. But this is actually where you'd want to take that next step and look at their polygenic risk score, because that is going to give you actionable information. And of course, we can use it as an add-on to existing risk assessments, like those risk calculators and models that we discussed, and of course, the monogenic testing. Now, in terms of the test itself, it's quite rigorously validated. So it's clinically validated as a laboratory development test processed in CLIA and CAP laboratory environments using genome-wide microarray technology. So it's fairly state-of-the-art. It's ordered by healthcare providers, typically through EMR integration or the Allelica platform if you don't quite have that sort of setup. And the results are delivered either via the EMR or the Allelica platform. And we can go into some of those details when it comes to the nuts and bolts if there is interest. And the test results are disclosed to the patient by the healthcare provider. So some may ask, well, does this come directly to the patient? But it is, in fact, healthcare mediated. So, we would sort of be the arbitrators of that information because, of course, we want to provide it to the patient in the right lens. So how does it work? Well, we place the test order online, right? So this is quite streamlined. And if you take a look at the Allelica website and platform, you'll actually see the user friendliness is above and beyond what we would typically see in this space. The patient then signs a consent form, performs a non-invasive saliva swab. We, in our practice, do it on site. The patient can also do it at home if it's more convenient for them. That is sent back, and the patient's DNA sample is analyzed with state-of-the-art genome-wide coverage technology, and a clinical report is delivered to the provider. We're going to show you what that clinical report looks like and how straightforward it is and easy to interpret. And today, we'll also discuss how to really analyze that report for what it is and get the best insights. Now, you may say, well, I've heard about polygenic risk scoring, and I've heard of other companies or other organizations who provide this as well. What makes Allelica so special? Well, Allelica performs a genetic ancestry assessment for every single patient tested to ensure the predictive results. And this is very, very important because this has been validated and trained on multiple biobanks, whereas prior polygenic risk scoring assessments are mostly done in a Eurocentric or European cohort. And this is of high value, especially as we have a multicultural, multi-ethnic population, which continues to grow. And in Allelica's case, this PRS is adjusted for each patient's unique genetic ancestry makeup. And so those PRSs and relative risks are compared to population are adjusted based on the patient's ancestry. And this is important because when we talk about equity in healthcare, we want to be sure we're capturing an appropriate assessment. So this is a very, very high value, and it is of importance. Now, for coronary artery disease and actually breast cancer, just sort of put that there in parentheses as well, these single nucleotide polymorphisms in each score are specific to each patient's ancestry. So very important to note, and you can see this Nature article where there's more information about this specific topic. So how do you communicate these PRS testing results? Well, we're going to go over a sample, but basically PRS tells you your risk compared to the average population based on your genetics. It's important to note, and when you talk to your patients, that genetics are not a destiny, right? This is not the type of monogenic testing for some sort of rare disease that leads to early mortality and you can't do anything about it. In cardiovascular disease, I always tell our patients and actually our healthcare professionals, we are very fortunate because we are in a position where we can diagnose almost anything in cardiovascular disease and treat almost anything in cardiovascular disease, and oftentimes quite durably, and give wonderful results. So in this specific case, especially when we're looking at genetic assessments, this is not necessarily a diagnosis of disease and is more of a sort of a precision tool, if you want to put it that way. And in fact, there's a lot that we can do based on this result. It's not like you're destined to a poor destiny. And even with a high PRS result, absolute risk can absolutely be reduced. Lifestyle changes, therapeutic interventions can reduce these modifiable risk factors and reduce that overall risk of disease. So high PRS is genetic as well. And one thing that you should note is that family members should be tested. So like all other genetic testing, if you have positive genetic testing, it often leads to cascade testing. So it is one of these situations where if you in fact find that a patient has high polygenic risk score, you would want to advocate to that patient that family members are tested as well. So let's talk about these results. Now, you'll see this little schematic there on the right side, and you'll see this commonly on the reports. It's just one part of it. But the beauty of the PRS platform with Allelica is that interpreting results is actually a breeze. It's basically binary. It's either you're high risk or you're not. So you're either a high PRS result or you're a not elevated PRS result. And if you're in a high PRS result, this is when your PRS is at or above the high risk threshold for that patient's specific genetic ancestry. And there we actually indicate whether there's a twofold or threefold risk compared to the rest of the population based on percentile. And of course, these percentiles can change depending on what PRSs you're looking at. But for CAD, this is how it looks. And with a not elevated PRS, basically, you're not in those categories. And by definition, you are not in a high risk category, AKA the patient's risk is not increased compared to the rest of the population. So let's walk through a sample report. This is what you'll see, and depending on how your EMR is set up, most are such that patients can often see what gets uploaded as well. So the report is sort of done in a way where patients can still feel empowered by the information, but you can still get those clinical insights that you're looking for. And so we'll start there on the left side and look at this. Well, of course, we have the company name, the patient information nicely, clearly labeled. And then we talk about the actual report. And the analysis is fairly straightforward. We look at the relative risk in the results, what the high risk threshold is, and then the percentile for their polygenic risk score, and what, again, that percentile high threshold is. I actually want you to zoom over to the right where we had shown you a portion of this report previously. And the summary actually displays this very nicely. Based on this PRS result in the 96th percentile for this patient, the relative risk of developing coronary disease is increased by about three times compared to the rest of the population. So this is very accurate in terms of giving information. And it is mentioned here, this is considered to be high risk, and that is explained there at the bottom for both healthcare professionals and patients alike, that this is looking at many genetic variants spread across the genome. Relative risk of CAD is calculated by comparing the tested individual's PRS to a reference population of similar ancestry, and it talks about those high risk thresholds over twofold and threefold. And now here are the implications. This is actually quite nice because it sort of just outlines what you might want to do with this patient. You might want to consider checking a lipid profile if you haven't already. Many of these patients obviously will already. If the patient is at borderline or intermediate 10-year ASCVD risk, then we can consider initiating lipid-lowering therapies based on this. And it's also noted here, which is very important, that a threefold increased risk is equivalent to a CAD risk from familial hypercholesterolemia. So it can give you some sort of scale in terms of what this really means in clinical terms, and talks about some other implications, including not looking for rare, variants of FH genes. So you'd want to consider FH monogenic testing if you're worried about that as well. Because again, the polygenic risk scoring is not meant to supplant monogenic testing. It's supposed to essentially complement it. And of course, you want to engage these patients in risk factor counseling, exercise, alcohol consumption, et cetera. And again, it does remind you about the cascade testing portion. Okay, so with that said, I'm going to move on to a few clinical cases so this all comes to light. And then, of course, we're happy to do the questions and answers. So this is patient X, 52-year-old gentleman with European ancestry. His LDL-C is 125 milligrams per deciliter. And based on the pooled cohorts equation, his 10-year ASCVD risk is 7.4%. So, of course, this is quite borderline with 7.5% sort of being that typical threshold. No hypertension, diabetes, or smoking, right? This is probably a sort of a classic patient you might see in the office. So this is a perfect use scenario where you'd want to get more information. And in fact, PRS testing was recommended because of this borderline risk and that moderate LDL elevation. And the result in this case is that he was at the 98th percentile PRS for European ancestry, which again, as we discussed, is in that 3 times CHD risk versus average category. So based on this, the clinician was much more comfortable initiating statin therapy. The patient was actually much more interested in doing so. And we ordered cardiac CT imaging as well, which showed subclinical coronary plaque, which all sort of matches what we're seeing here. And so in summary, the patient's therapy was intensified. In this case, we initiated statin therapy, and now he's monitored more closely for progression of disease clinically. We'll jump into patient J, who's a 46-year-old female of African-American ancestry with an LDL-C of 135 milligrams per deciliter. Positive family history of early MI, we'd be already concerned. No hypertension, diabetes, or smoking. But here we see something interesting, 10-year PCE risk just based on calculations in this low to intermediate category. Now, this is someone in real life we'd probably be quite worried about, and we may even bypass that PCE estimate and say, hey, this is someone I'm really worried about, I may want to treat. But then it may also make you pause because you'd say, well, those pooled cohort equation is actually quite powerful, and our risk predictive calculators are quite powerful. So maybe I just need to pause and think about it. And this is exactly where you'd want to consider PRS testing because of this family history, moderate LDL-C, and just our overall level of concern. Now, in her case, she was actually in the 38th percentile based on ancestry and based on the PRS algorithm. No statin therapy was started in this case. The patient received reassurance, and we avoided overtreatment in this case. But of course, we don't just say, hey, you're fine, see you later. We still want to maintain that close monitoring follow-up. We want to know what's going on with their LDL and follow their lipid panel very closely. We want to potentially rerun these calculations every so often. We want to know if something's changed in the family history. We may consider doing some form of imaging. So it's not like the journey is over. It's just that for now, we've been able to safely defer statin therapy and feel fairly confident that this patient's going to be fine in the short to intermediate term. And then patient M, 60-year-old male of South Asian ancestry, LDL-C of 110, BMI not terrible, but overweight, 28, no diabetes, hypertension, or smoking, ASCVD 10-year risk, 6.1%, but of course may be underestimated due to ancestry. So we did PRS testing for this patient, and they were in the 96th percentile for the South Asian population, which is important because if this patient was tested among a reference population, he may potentially be sort of miscategorized. So the clinician opted, in this case, us, we opted for early statin initiation despite these modest clinical risk factors. This is someone who could easily fall under the radar. And imaging did, in fact, confirm subclinical atherosclerosis. So this allowed for timely intervention and risk management aligned with these genetic findings. So with all that said, we'll move on to the Q&A. I'll actually stop sharing my screen here and just want to thank you for your attention.
Perfect. Thank you very much, Dr. Tadwalkar. That was very interesting and very insightful. We do have a couple of questions here, so I'll go ahead and get started with those. So the first one we have is about patient management. So has PRS testing changed management of any patients with a strong family history?
Yes, absolutely. So this is actually a perfect use scenario for PRS testing. And in fact, there's actually a clinical trial that is worth mentioning that actually looks at this specific question. So in more granular terms. So there's actually the MI genes trial. This actually looked at 200 or so individuals who were in an intermediate risk category and looked at sort of separated them into cohorts, those who were sort of just stratified based on traditional clinical parameters like pooled cohorts equation, et cetera, and how we'd normally clinically stratify risk, and then an integrated risk score looking at polygenic risk scoring as well. And it turns out that in these individuals, we actually saw earlier initiation of statin and that patients were more likely to adhere to statin therapy, and we actually saw lower LDL levels. So This is very important. That was all clinically significant and is very well delineated in this paper. And in fact, we actually have follow-up on that, which we can get to if needed. But this is a perfect example of how having PRS results can actually drive things clinically in a way that is not just hearsay. Like we actually have the data to show that it can improve clinical parameters.
Perfect. Thank you very much. Sorry, I'm just going through the questions because there are a lot flowing in, which is exciting.
Great.
Okay. So let me start with another one. Okay, this is about the calcium score. So is polygenic risk score testing more effective or better than calcium score?
Okay, I'm super happy that this question came up because we often think of calcium scoring as our holy grail when it comes to risk assessment. And that perception actually doesn't have to change because for the right type of population, calcium scoring is wonderful. In fact, the data behind it are excellent. And again, just to sort of be more granular and to bring it back into cardiology terms, a calcium score of 0 predicts very low risk for cardiovascular events over a 10-year period. Are there exceptions? Of course there can be, but this is very helpful. Now, what I will tell people, just to keep it very simple, is that PRS testing is in fact complementary to calcium scoring. This is not meant to replace it. This is complementary. We're looking at something completely different. We're looking at germline genetic risk. And this can actually be looked at a much younger age. So this is actually a perfect situation where if we have, especially a younger patient, they don't quite yet qualify for calcium scanning, but maybe under our current clinical paradigm, we may consider extending them to have a calcium score at a youngish age, let's say maybe 5 or 10 years before they're supposed to. The score is typically going to be 0, and then we're kind of still left scratching our heads because if they have other clinical risk factors, for example, they have high LDLs, they have a strong family history, we still have a difficult time really understanding where they're at because maybe they just haven't really yet developed disease. So this is actually where PRS testing can be quite complementary because now we can get an understanding of their genetic or germline risk. And this is much more clinically actionable than getting a calcium score at that point in their lives. However, even for those who are eligible for calcium scanning, again, this is not looking at the same thing. So it's going to be complementary data. So, this is, again, meant to sort of be alongside calcium scoring, not supplanted.
Thank you very much. And then I'm going to collate a couple questions because there are a couple of different questions here about ancestry adjustment. So I guess sort of the recurring theme is asking about using this test in individuals who are non-European. So is the test less accurate for individuals who are of non-European descent?
I'm super happy you asked this because this is actually where Allelica excels because the entire platform was built from the sort of understanding that we want to be applicable to a wide population. And so the initial training and validation of this data actually came from a whole diverse set of biobanks. It wasn't just UK Biobank. They looked at the Biobank Japan and a number of other large biobanks where these genome-wide association studies were actually done. And then beyond just that initial sort of data collation and training, basically that was then validated externally. And all of that data is actually published. And this is actually what really separates Allelica's platform is that we really sort of get that ancestry specific insight, which is remarkably helpful, especially in a population like ours in the United States that is growing multi-ethnic very quickly. And if you're in a place like where I live, which is in Los Angeles, this is just the standard, right? So we don't always just sort of see the standard European, sort of population where a lot of the data is sort of skewed. So I find this to be a strong, use for using the Allelica platform specifically, especially since we have the academic data and rigor behind it. I mean, it just sort of makes sense.
Thank you. Another question here. So in these patients, the focus is on a single CAD PRS. Wouldn't it provide more information by using a set of different PRSs, for example, diabetes, hypertension? If yes, does Allelica provide ways to combine PRS?
Yes, thank you for asking. So yes, today's webinar was really focused on CAD because as cardiologists, that's what we're interested in. And of course, it's a large driver of morbidity and mortality. So obviously, it makes sense that CAD is going to be a large proportion of this. Now, with that said, Alenica does actually offer PRS. Now, you may remember, just to backtrack for a second, I talked about how you can pretty much run PRSs for anything that we have strong data for. And in fact, we actually do have additional cardiovascular insights. And part of the reason personally I actually use Alenica is because we have robust PRSs information, so to say, and data in multiple categories. So yes, you can run it for stroke. You can run it for diabetes risk. You can use it to determine how much of someone's hyperlipidemia is polygenic. How much what is their likelihood for hypertension, things of that nature. And so because of that, I actually run it as a standard because that does give some further insights. But I do put a little bit more weight on the CAD portion, just being a cardiologist. However, if you're not a cardiologist and you're an independent practitioner or you're a little more holistic with your care, you certainly can run these PRSs and feel quite confident in the results that you obtain.
Thank you. Another one here. So in patients with already documented CAD and who are already on a lipid modifying therapy, is there a benefit to PRS testing?
Right. I want to answer this like as carefully as possible. I think, the short answer is there's less of a need for it because I think we already have a good understanding of what we need to do. However, it can still provide value. So, for example, in my patient population, I may have a patient who has CAD and has maybe an LDL of 70 on statin, and maybe they're not maxed out on the dose and they're kind of reluctant and they may say, hey, you're telling me that you should get my LDL lower, but I don't know if I want to do that. And I don't know if I want to bring that statin, dose up, or I don't know if I need advanced lipid lowering therapies. I'm just not convinced I'm doing fine, doctor. Like, why are you telling me this? Like, every other doctor tells me I'm doing okay. And so this is actually where polygenic risk scoring could potentially be of value because let's say they remain in a high risk category. This is yet not just another data point, but a precision medicine tool that actually tells us that, hey, you are in a very high risk category. And if your coronary disease and/or event didn't already prove that to you, you are definitely genetically prone to this. And, we really should think about being more intensive about your management. So in those clinical cases, you can potentially use CAD PRS. But to be fair and to be non-biased, so to say, as patients get older, as they have documented disease, as we're looking at more of the secondary prevention population, there may be less use cases, but there still can be some value. Another place that it can be of value anyway is maybe you have a patient who's really well managed. They've had an event, they have a stent, they're being treated appropriately, but they want to protect their family. So we're going to run your CAD PRS and say, hey, if you're in a high risk category, or if they find out they're in a high risk category, now we can do that cascade testing and then tell their other family members, hey, listen, like you should really do this because now we have a technology to determine whether in fact you are at high genetic risk. So that is another use case.
Perfect. Thank you very much. Just going through here. Okay, another a question about like the actionability and patient behavior. So the question, has returning PRS results improved patient initiation or adherence to statin therapy?
Yes. And in fact, we actually touched on this and you should actually look it up. Go look up something called the MI genes trial. And in that specific situation, when these patients received a PRS score and an integrated risk score, sort of looking at all their clinical risk factors plus the PRSs, they were more likely to not only be initiated on statin, but actually stay on it over a long-term follow-up period. And actually, this is preprint data. This came out very recently. Looking at the long-term follow-up of the MI gene study, these patients were actually found to have a lower risk of major adverse cardiovascular events. So there definitely is a clear driver in terms of patient adherence and in terms of patient outcomes. And it's really exciting to see that data, which is what we all expected anyway. But it's good to sort of see it really come to light that this is not just a fly-by-night technology, that this is the real deal when it comes to clinical actionability.
Thank you again. All right, another one here. Very informative. I am interested to know if using the tool that contains both PRS and other clinical parameters results in different outcomes for patients. This as opposed to your framework that uses PRS to inform screening and intervention.
I guess I just want to make sure I clarify that correctly, like meaning that using the additional PRS markers, like to sort of help personalize sort of a treatment plan, is that kind of, I think, what's being asked?
Yeah, so my understanding so using the PRS together with other clinical parameters, if that results in different outcomes for patients.
Sure. I think a lot of that, information is more anecdotal, but I'll tell you, being a busy practicing cardiologist, like I'll be the first one to tell you that I'm looking at all those clinical parameters first. Like, we're not talking about going rogue and just, doing PRSs alone and kind of using that to sort of judge all of our clinical decision making. A lot of these patients, for me, I'm very sort of being in the prevention space. I really want to know as much as I possibly can. And to be honest, like a lot of that is patient driven. Like, our patients are particularly motivated. It may just be a little bit of a bias of where I am, but they're particularly motivated and they want that information. So having that information is often complementary to all the other stuff that we've done. These patients already have lipid panels. They already have calcium scoring. We've done other forms of testing, maybe some carotid screening, et cetera. So yes, in my specific case, I would say that the PRSs are complementary with all that additional information. We use it all together to make that clinical decision. Now, could you use, just to sort of be the other side of it, could you use PRSs alone? I don't know if I would necessarily advocate that by itself. You can see in our cases actually that, we have all of our baseline data to make those clinical assessments. So it's really validated in the context of using other risk markers. So, we would definitely actually encourage that we use PRS alongside other validated markers.
Thank you. Another one here. So how would you approach discussing a high PRS result with an asymptomatic patient when other markers seem to be reassuring?
Yes, this is where clinical context really matters. It can be challenging for some patients to stomach that result, and some may even want to dismiss it. But because of what we know from the data, we know that a high PRS score, regardless of what else is happening, does confer risk. Now, how much risk does it confer? This can be a little bit of a challenging question to answer, sort of on the surface, but actually we have that information. So in the PRS risk score, if they're in that high threshold, again, we talk about relative risk in that report, right? So we know exactly what that means in clinical terms. If that still seems a little bit nebulous, what I will tell people, think of having a high PRS as having a significant risk factor. Best ones I can provide are maybe a patient who's smoking, right? So equivalent to someone who's a smoker, or equivalent to someone who has an LDL over 190. And sort of use that for your clinical decision making. So it's like you had an asymptomatic patient who has an LDL of 190. What would you do for that patient? So same sort of idea. Maybe their lipids are fine, maybe they look okay, clinically they're doing all right, but they have a high PRS. So it's sort of like lurking in the background. So this is the situation where you really kind of want to stick to your basics and double down on them. You really want to go into those lifestyle measures. You really want to get more intensive and really start to grill them about how much activity they're really doing. Is their diet really that good? You really want to get into the nitty gritty of their family history. Oh, they may say, hey, my father had an MI, but I can't remember what age. It's like, go find out, because we really want to know this information. And of course, we're going to be quicker to initiate pharmacotherapy if it looks like it's indicated. And in some cases where, it looks like, that PRS is high, oftentimes we're following these patients, pretty closely. If we're just still kind of like in the dark or we're not sure, we may follow them serially with lipid panels. And if the second they sort of have that elevation or we see some other sort of clinical sign that things are changing, subclinical athero, whatever it is, we're quick to jump on the pharmacotherapy train and make sure that they're well managed.
Thank you very much. We do still have a couple of other questions. I don't think we're going to have time to get to all of them. A couple of them are pretty involved, which is great. So we can follow up offline with those. We did slot 45 minutes today, so I want to be mindful of everyone's time. But I want to thank you so much, Dr. Tadwalkar, for sharing all of your insights, the presentation, for taking all of our audience members' questions here. If anyone does have any follow-up questions beyond the ones in the chat that we can see and follow up offline, you can feel free to reach out to Alelica. I want to thank everyone so much for joining. If you would like a recording of the session, don't hesitate to reach out. You can just write to info@alelica.com and we'll be sure to get that over to you. But yeah, thank you so much everyone for joining. And we wish everyone a great rest of your day.
Thank you very much.
Thanks, Dr. Tadwalkar. Thank you, everyone. Bye.
My pleasure.